we see a ton of neuropathy patients. A lot of people get to a point of desperation where they're just willing to do anything.
Yeah, we see those patients all the time.
Yes.
They are. I went through this with my primary care for 6 months. Then they sent me to the orthopedic surgeon. They maybe did an injection or two. They did an MRI. I'm not a surgery candidate. They sent me to physical therapy. They sent me to a neurologist. And I'm literally like, I've lost my job. I can't enjoy time with my family. I'm not, playing golf or whatever anymore. People literally have they've lost hope. So the stimulator is a great option for that. Sometimes if you've been on a medication for a long time, it loses its efficacy. Well, let's change you to a different medication. Well, we can change you to a different dose of stimulation, re-energize your body to get the relief that it needs.
Welcome to the show. I'm joined today with Dr. Benjamin Sloop, and he is a board-certified anesthesiologist and pain specialist. So welcome, Dr. Sloop.
Thanks, David. Thanks for having me.
Absolutely. So tell me a little bit about your background.
So did my college undergrad at Virginia Tech. I'm kind of from that area in Virginia, so kind of close to home. Was interested in biology, chemistry, medical stuff. Actually, as a kid, I think at one point I wrote a paper on being a chiropractor, which is interesting, given where I'm at now and our current setup with our clinic. And from there went to Eastern Virginia Medical School. I went there from a rural area myself thinking I'm probably going to go into primary care, internal medicine or something like that. But man, I got really bored in those rotations.
Yeah.
And I kind of liked surgery, but there were some other issues that I thought maybe surgery wasn't the best fit for me. And then I kind of I had a lot of buddies who were doing anesthesia these guys I studied with the whole time in med school. And they're like, try anesthesia. So I tried it, and we had a great preceptor there, and it just kind of clicked. It was like, yes, I like this. This is exciting. I'm in the OR. I'm not necessarily doing surgery. I did a residency in anesthesiology at University of Kentucky in Lexington. And during that time, I think I had another realization of maybe anesthesiology isn't the best fit for me. I liked what I did, but I kind of missed getting some feedback from patients. I missed developing a relationship with them.
Well, that makes sense. So because you obviously would have way less rapport
None.
with the patient because they're knocked
Zero.
out.
Zero, yeah.
I got it.
Yeah,
Okay.
Zero. So the patient's asleep. You never hear if they do good or bad. They never
Right.
don't. Well, you hear if you do bad, right? You never hear, a patient never comes back and says thank you to the anesthesiologist. Not that that's a huge deal, but it does matter. And
Less rewarding.
Yeah, it's rewarding, and
that.
it mattered to me. And a lot of people go to chronic pain out of anesthesiology and pain management. And so I did some rotations in that. I got to know several of the guys that were involved with the pain fellowship there at UK. And that kind of helped solidify my decision to do the pain management. So I did that fellowship for a year. Just knew immediately this is exactly what I need to be doing and where I need to be. And that's where I learned all about the injections, all about the stimulators, about managing pain medicine, a lot about spine anatomy and pain. And there's a lot of psychological components to pain that's also pretty intriguing. That's kind of my education background, if you will, and kind of how I got from anesthesia into pain. I think my patients notice that. Pain doctors, I think, have maybe a reputation of sometimes not being the most compassionate, nicest, listening kind of people.
Well, a lot of them don't have a great reputation just because there's been, especially in the area that we're in here in Ohio and Indiana, Kentucky. I mean, it's kind of, and I'm sure Virginia's no different.
Anywhere Appalachia is,
it's been the opioid epidemic, and so I guess my question would be when you were in that transition, you were doing the anesthesia, and then you decided to go pain management, and you were going down that route. Was there something specific that you saw that on the interventional side of things that made you want to go that way versus med management?
Yeah, absolutely. I think one, I just like working with my hands. I like the technical aspect of the interventional practice. You write a patient pain medicines, and there are people who need pain medicines. I will never dispute that. There are a lot of really good people on pain medicines. There's probably a lot of people who don't need to be on them too.
Sure.
And you can probably say that about anything. But, writing somebody pain medicines, I would see them back in a couple of weeks, and I would ask them, like, how's the medicines doing for you? The answer I almost always got was, I guess they take the edge off. And it wasn't uncommon that people were having side effects, getting constipated or itching or making them drowsy or whatever. And that would really limit like how effective they could be for people. So I started to think, man, there's just got to be a better way. Patients who were on pain medicines just typically weren't super happy with the therapy. I get that when somebody hurts and you're in pain, you'll take any relief that you can get. But I just wasn't happy with, from myself, treating a patient and getting the response of, well, it takes the edge off. That just didn't seem super effective to me.
Doesn't feel like it's getting to the source.
Yeah, exactly. And there's just, pain medicines they are addictive. They have a bad reputation, right or wrong. I got involved in working a little bit in some addiction clinics on the side and saw some of the more negative sides of that. And that was honestly some of the most rewarding work that I did, was treating people who had gotten addicted, be it from a doctor in pain medicines or from other sources. But I think that it just opened my eyes to how there's got to be a better way. The flip side of that is when I would do, and I'm doing all of this together in one practice. I'm writing pain medicines, I'm doing injections, I'm doing stimulators, I'm sending people for surgery referrals, like just kind of a general pain practice. And when I'm doing injections on people, people are coming back and saying, I'm 70 or 80% better, I'm exercising, I'm doing the things that I want to do. I'm not worried about taking a pill, I'm not worried about keeping that locked and safe. I'm not worried about all the other things that come around with pain medicines, or worried about being addicted to them. And so it just seemed to be, one, more effective for our patients, and two, just a bigger amount of freedom for people to not have to worry about keeping track of a pill, taking it exactly as it's prescribed, not overtaking it, not mixing it with this other medication that you take, managing the constipation or whatever side effect. And not to say that the injections don't have their own, potential, side effects or whatever. But in my experience, it was that the patients who got injections did a lot better, a lot longer, didn't have as many issues as the people who were on the pain medicines. And so it just made me want to be more aggressive with that approach. And I think that people have seen what the opioid crisis has done to their families. Especially in this area, like you mentioned. Yeah. And people are scared to take them now. And so people want choices, and they don't always get those choices. Sometimes it can be hard to find a pain doctor who wants to do some of the interventional stuff, or can even present it in a way that's palatable for you.
Yeah.
Sometimes you hear about, an injection in my spine. Well, I'm not going to have that. And the pain doctor can say, well, wait a second, let's maybe rephrase this or teach you about it.
Yeah.
So that it's something that can actually be more acceptable to you.
Well, I do think it comes down to educating the patient on consequences. I mean, when you've got somebody that is horribly in the pain cycle, I think that it is super important to break that pain cycle.
Yeah.
Because a lot of people get to a point of desperation where they're just willing to do anything.
Yeah. We see those patients all the time.
Yes.
They are, I went through this with my primary care for 6 months. Then they sent me to the orthopedic surgeon. They maybe did an injection or two. They did an MRI. I'm not a surgery candidate. They sent me to physical therapy. They sent me to a neurologist. I bought every brace on Amazon. I hear that all the time. And I'm literally I've lost my job. I can't enjoy time with my family. I'm not, playing golf or whatever anymore. People literally have they've lost hope. And I just get how frustrating that can be. And I think it's important. I think at doctors, we kind of lost this. It's important to offer your patients hope.
Yes.
Have an answer for them, be willing to do something for them. I think there's just the last, maybe since COVID, the medical community has gotten kind of negative about things. And, you go to your doctor, you want some hope. I think that's the biggest
Absolutely.
thing. I think that's the biggest thing people are looking for, maybe more than pain relief. It's just give me a little bit of hope. So there's power in that, and just being able to offer them something different that's not an opiate or not a pill, offering something that can maybe like give them long-term relief. That's important.
Specifically up here in Mason, where we're at, we see a ton of neuropathy patients. And most of those neuropathy patients, they've been everywhere.
Sure.
They've been to their primary care. I mean, I can't hardly think of anybody that just got neuropathy that comes in as a patient. It's very few and far between. Most of them have been to their primary care. Primary care said there's either nothing that they can do or go and see the neurologist. They've been to the neurologist. They get their nerve conduction or EMG, get told that they have neuropathy, which we already knew.
Yep.
And get their gabapentin prescription and it feels like also, just this is a bit of a side note, but it does feel like, and I want your opinion on this, it does feel like a lot of these guys are writing gabapentin nowadays instead of narcotics, maybe potentially because they're afraid of writing the narcotics.
Sure. Yeah, I think you're right. I think gabapentin use has ballooned, probably due to the opioid crisis. People say, well, I don't really want to write you a narcotic medicine. And so gabapentin's being overprescribed for things like back pain or joint pain or whatever,
right,
just to kind of keep somebody off of an opiate. But it's really doesn't work well for those other indications.
Well, I don't think it was designed for it. I think originally it was like class as an anticonvulsant.
Yeah, it's a seizure medicine.
Yeah.
Yeah.
So that's interesting. So that is definitely a trend that we've seen, and now it seems
yeah,
like
that's a well documented thing too. I've seen several articles in the medical literature and about gabapentin being overprescribed now, and also like we're seeing more like gabapentin overdoses and things that you'll see that we didn't used to see because it is being overprescribed. And I think people are so hesitant to write like a narcotic script for somebody.
Well, and I've even seen some states that have tried to classify gabapentin now as a controlled substance.
Well, in Kentucky it is.
So very interesting trend there. I think it comes down to, at the end of the day, a lack of an effective treatment for some of these more chronic conditions.
Yeah.
And because diabetes is so huge in the United States, and there's a whole lot of people now suffering, especially the baby boomers, the older generation, suffering from painful diabetic neuropathy.
Sure.
So let's talk about that a little bit. Can you tell everybody what is neuropathy?
Yeah, so neuropathy is just basically catch-all phrase for like nerve damage. Can come from a variety of sources. I think diabetes is probably the leading cause that we're seeing now in the United States. I think a close second, probably like spine issues, back problems. People who've had a back surgery, people who have spinal stenosis or a herniated disc.
We see a lot of chemo-induced as well.
A ton of chemo-induced. I think we have seen several patients who have COVID kind of induced, so it can be from a viral source. People have chronic medical conditions, thyroid problems, kidney problems, liver problems, sometimes will develop that. Toxic exposures, we have a lot of factory workers here, and sometimes those kind of things can cause neuropathy as well. You can also just have neuropathy from multiple sources. It doesn't have to be just one. It can be diabetes and whatever other cause that we just listed. It could also be idiopathic, meaning you just have it, like we don't really have a reason. We know that doing nerve conduction or EMGs on older people, we know that their latency decreases as they get older. So some of it can be just like age related as well.
Makes sense.
But yeah, there's not a lot of great like treatments. We can't go into every single little nerve and like regenerate it and reheal it and all those things.
Well, let's talk a little bit about that. So tell me a little bit about what you can do and what you have seen in this setting on the interventional pain side for treating people that are suffering from neuropathy. I think it's really important to go into that because we see so many patients that are literally at their wit's end.
Yeah.
They're at the end of the rope, they're at the end of the line. They've been to their primary care, they've been to their neurologist, and they're not getting real help. Or worse, back to your point on giving patients hope, a lot of these doctors have told them, well, there's just nothing that can be done.
Sure.
So
people hear that a lot.
Yeah. So from your role and experience and training, what have you seen that is the most effective at treating neuropathy?
Yeah, so I think the biggest thing that we have to offer, and I think a lot of like good pain doctors have probably been doing this for a long time, has been treating this with stimulators or neuromodulation. It just got an indication a couple of years ago. The Nevro company did their Senza RCT randomized controlled trial.
So for those of you that don't know, so Nevro is they specialize in, but they have neuromodulation. They have a special frequency, my understanding, using 10 hertz on, for those of you that know what a TINS unit is, it is basically, they've got a battery generator, and my understanding, and obviously I want you to go more into this, is that they're stimulating the spinal column.
Correct.
And that's doing what exactly?
Yeah, so let's rewind a little bit.
Sure.
So they did a study treating patients with painful diabetic neuropathy with the spinal cord stimulators, and they had just phenomenal results. And it's a 2-year study. It's kind of hard to get a study out 2 years. Most studies you'll see are 6 months or a year. So the fact that they got this out to 2 years is pretty amazing. I think they are backed now by, or not backed now, they are on, I think it's the American Society of Endocrinology. It's one of their top level treatments that they're recommending now for patients with painful diabetic neuropathy. So, but I think pain doctors who understood things, maybe without studies, which if you're a good doctor, you kind of go that way. We're doing these before for this. I had several patients that I'd done these for in Kentucky, and they were getting great results, and that was way before the study came out. So I think that study brought it from maybe something in the background more to the foreground, and certainly this endorsement by the Endocrinology Society really puts it out there to all the other like internal medicine doctors, the endocrinologists, the primary care doctors who see this stuff on a daily basis, who may not be quite as in tune to like the spinal cord stimulator or, you know, interventional pain kind of world, introducing it to them. So it certainly has brought this to the forefront and has been a big increase in the indication for using spinal cord stimulators. But back to your question about what they actually do. So it uses a little bit of electrical energy, and what that energy does is it's changing the way that those nerves in your spine actually send their pain signals. As we know, we don't have exact details on this, but we're changing the actual chemical structure there and how that's sent and received and how it's perceived there in your spine. In one way, it kind of is a cover-up, but in another way, it's not. It's actually addressing at the level of the spine the issues that are there.
Well, and it's doing it without drugs.
Correct.
So I mean,
So,
I could see how that would be more appealing to, especially to a lot of these doctors that they don't want their patients addicted to the opiates or
a lot of patients don't want to take them, and a lot of doctors don't want to write them. And the pain medicines aren't super effective, like an oxycodone, or they're just not very effective for treating nerve pain. The stimulators, I think, are probably the best option right now for what we have in terms of treating neuropathy, nerve pain, and I think that indication, like I said, is growing and expanding. It's a super interesting therapy, and you know, it's been around since the 60s. A lot of people don't know that.
Wow, I didn't know that.
Yeah, the first case was done, I think, is in '67. It was a guy who had a lung cancer and was, I think, basically on palliative care. His pain was uncontrolled on all kinds of, I think, narcotic medications. Well, they put a stimulator lead up and stimulated that, and he got like amazing pain relief like quickly. And I don't think he lived a whole lot longer, but it provided good pain relief for him for the rest of his life, although be it short. Really crazy for something to go from the very first time it's being used to being FDA approved within a year or two.
Well, and I mean, I think that's great. I think that is probably a testament to how effective it is.
Sure, and
not that the FDA is very, you know,
and even how
popular
safe, and even how
anything.
safe it is. I
It's
think.
true. I mean, they don't just slide something through.
Correct.
That's a device like that.
Correct.
So can you speak to a little bit, because it's got a very aggressive name,
Yeah.
spinal cord
Yeah.
stimulator. So how invasive is this?
So I explain it to patients like this. You know, when women are in labor and they get a labor epidural,
Yeah.
you know, what we do is we use a needle You sit up on the side of the bed, we clean off your back with soap, we just don't use an x-ray camera or anything, we just kind of use landmarks, we put a needle into the epidural space, and then we put a catheter in. A catheter is just like, think of it like a little hose or a little tube, okay, and we infuse medication through that. And that medicine will make you, numb, and your legs are kind of weak, and so you can deliver the baby and not be in terrible pain. So the stimulator procedure is, it's very similar to that, but we take all these safety precautions. A lot of times we'll get an MRI first of your back to make sure that everything looks okay. We use an x-ray camera while we're doing it. A lot of times you have sedation on board to make sure that you're comfortable and not too anxious during the procedure. So it doesn't really take all that long. I find that most of mine are done within 15 or 20 minutes. And most of the time patients aren't any more uncomfortable than they are when we do a regular epidural or some of our other less invasive procedures. But you got to respect that we are working around the spine and the spinal cord. Yep. And so you got to be careful. You got to know what you're doing. You have to do things the right way. And I think people hear or read maybe bad stories or bad things happening. Those things, they do sometimes happen. But the risks of those are incredibly low. I think the things that I've read is a bleeding risk is probably, it depends a lot. Like if you're doing a young healthy person, that bleeding risk is a lot lower. And we're talking about serious bleeding events. Yeah. 1 in 200,000 versus maybe 1 in 50,000 to 1 in 10,000. Someone who's older and maybe they're on blood thinners or something like that. Certainly we worry about infection risks. Infection risks with trials are very low. Certainly there's always a risk with that. We put you on antibiotics during the trial just to prevent any sort of infection, totally prophylactic. Most of the infections I think that are reported are probably superficial. Certainly if there was an infection in your spine, that would be a bad, scary thing, but I think those are very uncommon. But bad things do happen, unfortunately, no matter how careful you are, and that's one of the hard things I think about being a physician and doing these kind of things. But I think that risk is incredibly low. I think if you were to have a serious problem with nerve damage or something, it would probably be a result of a bleeding problem or an infection in my mind. From the procedure itself, I think is pretty uncommon. Pretty minimal. Yeah.
So the whole thing's pretty minimally invasive.
Very minimally invasive.
Walk me through.
I don't even use an incision. We numb up the area with numbing medicine. I don't even make an incision. We put the needle in through the skin.
So it sounds very similar to the trial's very similar to an epidural type.
Correct. Very, very, very similar. The only difference is instead of injecting medications, we're putting a wire in. Yeah.
I got it.
Yep.
Okay.
Yep.
And so how long is that trial typically?
Trials are usually 7 days. We want to give the patient enough time to really experience it.
And how long is the procedure?
Procedure's 15 or 20 minutes typically.
That's really fast.
Yeah.
Okay. So 15 or 20 minutes, we don't have to use full anesthesia?
No, we just give a little sedation. So there are patients who don't want sedation for it, understandably so. But most people we give a little bit of, you're not going to go all the way to sleep, but we say it's going to help you relax a little bit during the procedure. We try to keep you awake, and part of the reason we keep you awake is there's safety built into keeping you awake. Because if my needle is or my wire is somewhere that it shouldn't be in your spine, you're going to tell me when you're awake versus when you're asleep. Then you wake up and all of a sudden, I have this terrible pain in my leg or I can't move my foot or whatever. So keeping you awake has an element of built-in safety there for us as well.
That makes sense. Okay, so they do the trial. How do you judge whether or not the trial is successful? Is that on you? Is that on the patient?
It's all the patient. People sometimes I think misunderstand the trial. Basically, it is an opportunity for you to experience what this therapy will be like if you have it implanted. I try to use the analogy of you're taking a car for a test drive, right? Like if you're driving the car down the street and it's making all kinds of noises and blowing smoke and whatever, and you're probably not going to buy that car, right?
Right.
So this is your test drive for your stimulator. You get to take this and keep it for a week, and you get to see if it meets your needs. We like to see at least 50% improvement.
So you get to try it before you buy it.
Try it before you buy it.
That's good.
We like to see at least 50% improvement. Technically that should be in pain. I think there are patients who come back and say, yeah, my pain's 50% better, but I'm walking more, I'm sleeping better, I feel better mentally, I'm taking less medicine. So you take all those things, those are things that you can't like quantify all the time, right? Even though maybe it's 50% pain relief, like I'm so much better in all these other things. I'm not using my walker, my cane, I can walk around. I cleaned my kitchen for the first time in a year. That's not a small thing for someone. And I think someone who's been dealing with pain, chronic pain, 50% is huge. So every little benefit that you can get when you're living this life that's so limited and isolating and debilitating because of pain is a huge improvement for you. So I try to encourage patients, don't just look at the pain, look at all the other factors in your life as well that can improve because of this. And it's not uncommon that we have people say, yeah, my pain's a lot better, but on top of that, like I'm just more active. My wife said that I'm not grumpy, you know?
That's great.
And I think that's,
it's important.
Yeah.
It's important.
We have people who go back to work after getting their simulator put in. We have people who go back to, their recreational hobbies that they want to do after they get them put in. I mean,
so they get their life back.
Yeah, it's remarkable.
And they're not addicted to drugs. I mean, I think that's huge. So they get the trial. Trial takes about 7 days. And then you do the implant. How invasive is the implant? How long does it take?
Sure. So the implant's it's surgery. There are 2 incisions that are about 2 inches long each.
Okay.
One for the wires, and we put an anchor around that wire to try to prevent any migration, and the other is for the battery. Everything's contained under the skin. We run anywhere from, it just depends on the patient and things, but anywhere 45 minutes to an hour, I'd say, is pretty typical for our implant cases.
And the patient's asleep.
Yeah, they have a full anesthesia during that time to be comfortable and get everything in there, obviously, how we need it to get in there. And really, it's pretty minimal recovery. Patients have a soreness for a couple of days usually. We do write some pain medicines for that, just for a couple of days. Honestly, I have a lot of patients who tell me they didn't even get them filled.
Right.
I don't want you to have something. I don't want you to,
Suffer
or be not able to do things you need to do. I think in the last 2 years, I've been asked like once or twice for more pain medications, right? And then, anytime you have an incision over your back, you got to let that heal. That usually takes about 2 weeks or so for those tissues to be healed up to the point where we say, you don't have to be quite as careful. We do tell people 6 weeks or so of restrictions. I don't want you to do anything too aggressive. You have to, I tell people like, look, I understand you got to go to the bathroom. You got to get in and out of bed. You got to get in and out of the car. You got to, cook and clean for yourself. But I want you doing those things carefully, slowly, being mindful that there's something in your back. And the reason we do that is we just don't want those wires to move until scar tissue has held them in place. And that's what really locks that in and prevents any kind of migration or anything.
That makes sense. So now, having done this, and we do quite a few of these nowadays because we see so many neuropathy patients, and also I believe there's an indication for failed back surgery.
There is.
Can you speak to that?
Yeah. So a lot of people have had a back surgery. I'm one of those people, and they still may have some residual pain, or unfortunately, sometimes people are worse after back surgery. We see that sometimes. Sometimes people have had a back surgery, maybe they need another one, but they don't necessarily want to go that route again. So the stimulator is a great option for that as well. Similar situation, similar scenario. We do a trial. You get to test it and keep it for yourself and see how much it helps you. Implant would be very similar as well. We see great results. I will say that I think the diabetic neuropathy is maybe a higher, or just neuropathy in general, is a higher percentage success rate than people who've had a big back surgery. When you've had a big back surgery, just your anatomy is different.
Especially if there's hardware, I imagine.
Yeah, if there's hardware in there. A lot of times people who've had back surgery, it's multiple levels that have issues. It's a little more widespread. Back pain seems to be a little bit harder to treat than the neuropathy pain, but we still get, I think, good results with people who have back pain with the stimulators. They are indicated for back pain as well. But I think that really where they shine the most is the neuropathy. But it's a great option for someone who has back pain and like they have still sciatica pain or back pain that radiates into their leg, like we call that a radiculopathy. It works, I think, very well for those patients as well.
That's amazing.
I had quite a few patients who, again, have had a back surgery, maybe didn't get the outcome or the result that they wanted, and then have gone the route of a stimulator, and then have had the stimulator really get them where they hoped a back surgery would get them.
That's great. So how often, in terms of your experience, how often do you do these procedures, trials and implants, and do you have a concept of how many you've done?
Sure.
I know you've done quite a few.
Sure, yeah. So I don't really keep great track of like how many I do. Maybe I should start doing that. But we're doing these every week. I think last week we did like 6 trials, and I think we did
it was 7 trials and 4
or 5 implants. That's a pretty good. That's, I would say, not unusual for us. So I think last year we did more than 100 trials. We did, I want to say 70 or 80 implants. So it's something that we're doing a lot. In my career, several hundred, I'm guessing. I don't know an exact number, but
So you've got a lot of experience with this.
Yeah, I think so.
That's great.
I think so.
Okay, so one thing on neuropathy that we see a lot in the clinics, and I know we had a conversation about this the other day just in my office when we were talking. Tell me a little bit about what you have seen in terms of the alleviation of some of the symptoms of neuropathy, like shooting pains, numbness specifically. I know numbness is a big one that comes in.
Yeah. I think studies back up a lot of this. Burning pain, I think we do very, very, very well with. If you have burning pain, I mean, I will look at you and be like, I can almost guarantee you that you're going to get like 60 or 70 or 80% relief from this burning pain, which is amazing.
It is.
There's not much in medicine that's that efficacious. Cold sensations, tingling, maybe not quite as robust, but good, but still good. Like I can still tell you probably 50 or 60% better. Numbness is an interesting one. I think numbness can be hard to treat, especially if the nerve is dead. And I think there's some literature and stuff to back that up as well, that if the nerve is still alive, then you can still treat and help it regenerate and regrow.
Absolutely.
And I think the stimulators do that. But I will say that we see patients getting improvement from their numbness as well. And there's, to my knowledge, there's nothing out there that helps numbness. Nothing. Whenever I talk to like the reps and some of the people at these companies, I'm saying, when are you going to do a study on numbness? Because, I mean, you talk about like pain is one thing, but when you can't feel your feet, you're more prone to like maybe, and I have a crazy story where a lady with neuropathy drove her car through our lobby into my office because she couldn't feel which pedal her foot was on, right?
It happens all the time. I know of another group out in California. I think they were giving a lunch talk, and we've done some lunch talks and things like that as well, but they had a patient that was, interested in coming to their lunch talk on neuropathy. Similar situation, headed to the event, couldn't tell the difference between the gas pedal and the brake, and gassed it into the restaurant.
Wild, right? So you talk about like pain is bad, but like how dangerous is neuropathy?
Very.
Well, then you have balance problems. So then you're more prone to fall. Falls is like one of the leading causes of morbidity and mortality in our patients over 65, and it's almost all preventable too, which is crazy. And then you talk about like infections and ulcers and amputations, and it's like numbness is maybe where we should be the most aggressive, just because of all the downstream effects of that are so bad and so consequential for patients. Numbness is more difficult to treat, but I will say that we have patients who get good results with numbness as well. I don't have a study to back that up. Unfortunately, it's something that I'm interested in working on. But and the other interesting thing about numbness is that it's not as immediate relief as maybe the burning, tingling, cold, other sensations. So you might not notice it as dramatically during the trial, but we have patients who come back 6 months, a year later and say, look, I've got feeling back in my feet again.
Yeah, more of like a long-term sort of, that's great.
Yeah. So it's really a remarkable treatment and doing some things that maybe other like taking gabapentin's not going to do that for you, right? Taking a drug's
Totally.
not going to do it. So I think that there's potential for the expansion of the indications here for stimulators to be more than just pain. I would love to see some studies. I would love to see some numbers and data on like actual numbness, because I think that there's huge potential there.
Well, and I think that's something we should put together, honestly. And frankly, like you said, the numbness is such a problem. And one of the biggest problems, especially for older people, who a lot of them have neuropathy these days, is the loss of independence.
Yep.
Because the moment you have an accident, or the moment you, I mean, and we've had several wild stories as well. Somebody stepped on an acorn, couldn't feel it. The shell got lodged in the foot, led to an amputation.
Yeah.
I know another person, and I was doing the intake with this individual with one of the physicians. This is prior to you being here, and we were doing this intake, and I'm talking to this guy about his neuropathy, and he's kind of minimizing it. I feel like a lot of people with neuropathy, because it's not like it just happened overnight.
Yeah.
You know, it's one of these things that's crept. It's like creeping nerve death.
Yeah.
And so, you know, they're sitting there, and the guy's kind of minimizing it, and the wife just stopped. She said, listen, this was over the holidays. It was winter. His feet were up by the fire, warming his feet.
Oh, no way.
And she walked in the living room from the kitchen and smelled something cooking.
And it was his feet.
He had no idea. And so, you know, this is some of the dangers that people run into, because you can't feel your feet. All of a sudden, something like that happens. You don't notice it. It gets infected. It could be a splinter. It could be a piece of metal, something you step on outside, just not paying attention.
Yeah, if it's numb, you don't feel it. You don't know that it's there. Well, that's why we always tell our patients in the clinic that have numbness, like, you keep a close eye on your feet. Check them at least twice a day, like morning and night, if nothing else, if not more frequently, because you step on something small and you don't know it's there, then that's just damage. And
well, it heads down the road to loss of independence. And then all of a sudden you can't have a driver's license. And nobody wants to go down the road of a loss of independence that I've seen.
Yeah.
So I think it's super important. So this is a great thing that you do. You get great results. We've got many testimonials on YouTube that everybody should look at and search, and please share that with anybody that you know that's suffering with neuropathy.
Yeah, the one thing that I tell patients too is, you know, one of your first comments was, it seems like it's like, do the trial. I think if you're suffering with these kind of issues, like, do the trial and just see for yourself. You owe it to yourself to spend a week with this therapy to see what it can do for you. If it doesn't do it, don't get it implanted, right? Like,
right.
But you owe it to yourself to do the trial and at least see what this can do for you, because they are so successful. Our patients are very happy, and like you said, regaining independence, doing the things that they want to do. So just be open to do the trial. And I get not everybody's ready for that kind of thing, but do the trial. Let the trial speak for itself. And a lot of people get worked up and worried about the implant, and they want to talk all about the implant. I said, well, you haven't even done the trial yet. Like, let's do the trial first, and then we can, you know, start worrying about all the other stuff. So if you're interested, if you have these issues, you don't want to be on medications, or we have a lot of patients who just can't take those medications for whatever reason, give the trial a shot.
It's a great solution, and covered by insurance. So covered by Medicare and most major medical insurance, and I'm working hard trying to expand the Medicaid coverage in the state of Ohio, because
that'd be great.
Well, I'll tell you, I mean, it's unfortunate that Ohio is about 65% on what they reimburse in terms of Medicare on spinal cord stimulation and most major
Well,
procedures.
you know a lot of the numbers on this, but I mean, a lot of times that doesn't even pay for the product that you're implanting, and it's like, well, you know, you have to run a business. You have to at least pay for what you're doing. But if you can't even pay for your facility and your workers, and for the device itself is expensive.
That's right.
You can't do that. So there's a lot of people out there who could benefit from this, who, if they're on Medicaid, it's just not an option.
It's unfortunate. You know, there's 4 or 5 states Indiana, I believe, is one of them, which is our neighbor here, that reimburse at least as much as Medicare or more. And I think it's part of a much larger problem with the opioid epidemic in this area. Everything has been very aligned to prescribe.
Sure.
And so when we introduce procedures that are super effective for pain and these conditions, and you don't need to prescribe, well, I don't know that pharmacy benefit managers
Sure.
that operate as the middlemen really like that. And so, I've been writing to a lot of politicians and,
Good for you, man.
people.
I think more people need to do that. I wish, send me some of that information. I would love to write some letters. You never know when something's going to resonate with somebody. Patients,
Absolutely.
Patients should write letters too and share their experience. It is sad that a narcotic pain medication will be covered for years and years and years and years and years for somebody, but a stimulator device that can be life-changing for someone, it isn't covered.
Well, it's also a point of fairness too. It's like you've got a population that is basically a poverty level population. They need the Medicaid to get proper health care. They should have access to proper health care. And when you've got a system that is aligned to prescribe versus getting the person the procedure that they need.
Sure. Well, is it almost
somebody's
like
got to look at that?
Yeah. Well, and it's almost like a tiered system too. It's like, you're in poverty and you're on Medicaid, so you get a lower level of care. That's
not right.
That's wrong on multiple levels.
Well, and just so everybody understands, to what we were talking about earlier, the equipment itself to do the procedure that is so effective is very, very expensive to the physician and clinic or group that's actually doing the trial or implant. It's a situation in Ohio where that is it would be a complete loss of thousands of dollars per procedure to do that actual, the spinal cord stimulator.
And you can't run at a loss because then you can't help the other patients either, right? So
unless you're a hospital.
Well, and then we talk about how there's a physician shortage and we need more clinics, and it's like, well, you can't keep your doors open if
you can't.
If you're, not making your money back on. It's not, it's not all about money. It's really about care for people who need care.
Well, and to the point on the hospital, the reason I brought that up is because these hospitals will do some of the procedures. However, you got to understand the reason that they're doing that. And the reason that they're doing that is because they're getting government grant money to accept Medicaid patients. And so they'll take the loss.
Yeah, I was always under the
because
impression
it's not really a loss.
Yeah, I was always under the impression that they got so much of a tax break or whatever for treating these patients, and they would just write it off as a charitable thing, and then that would lower their overall tax burden. And
it's a kickback system. It's a kickback system that's somehow legal. It's not, unfortunately, what somebody's everyday doctor or independent physician can do or participate in. And so the result is just, in my opinion, a system that is aligned to, okay, well, we can't afford to do it for this patient, so what's the next best thing?
Sure.
Well, we're going to write the prescription.
Sure.
And it's unfortunate. And like I said, I'm working very hard to try and get some attention to that issue and get some reform.
Well, I appreciate that. I'm interested to hear what responses you get and maybe to see some changes come down the pike with some of those things. I would love that.
Absolutely. All right, so let's pivot for a second. Let's talk about some other things that you do for interventional pain. Tell me a little bit about MILD.
So MILD is what it stands for minimally invasive lumbar decompression. This is a procedure that we do to treat a condition called spinal stenosis. So let's talk about spinal stenosis. Very prevalent in our older population. As we age, we get arthritis in our back. We have degenerative disc. We get certain ligaments in our spine get thick. And when you get all these things that are getting overgrown and thickened, it narrows your spinal canal, which is where your spinal cord is. And it can narrow it to the point where it can't send its signals well. And what that usually results in is the patient saying, I can't stand and walk very far. They typically will say something like, I feel pretty good when I'm sitting down, but I stand and walk, and it's usually a pretty reliable thing. They're like, I can go to the mailbox, but I can't get all the way. I get halfway back and I got to sit down. Or I can get to like the produce section of Kroger, but then I got to sit down after that.
I've heard it as shopping cart syndrome before.
Yeah. And so the other thing they'll tell you is like I lean forward way over the shopping cart, and that helps me go further. What that's doing is creating a little bit more space in your spinal canal, relieving some of that pressure on the spinal cord and allowing you to go a little bit further in that flex position. A lot of times people say it's like my back starts to hurt and ache, and then my legs get heavy and weak and tired, almost to the point where like I can't even move them.
Wow.
And like I have to, and it's like I have to sit down. It's not like I go sit down. It's like, no, I have to sit down. And they sit down, and it pretty quickly improves and gets better. And they say, well, I can get up and I can go again for whatever amount of time. And so it's a pretty debilitating issue. And
I would imagine working people, this is like very, very noticeable.
Sure.
Guys that work on their feet or factory workers, things like that.
Sure.
This is probably something that really they would notice
absolutely
quite a bit.
And so this mild is a treatment for that condition. And if you were to go see a surgeon, they would talk about doing like a laminotomy or laminectomy and actually taking off a whole piece of the bone to open up that spinal canal and create some space. Well, very specifically for mild, this procedure debulks a thick ligament that we get there called the ligamentum flavum, and it gets calcified as we get older, and it creates that spinal stenosis. And people, smarter than you and I have found out that we can go in with a couple of small tools through a small incision. We can thin out that ligament some, and by just thinning out that ligament a couple of millimeters, people get tremendous relief from this. And that it doesn't have to be as aggressive as a big surgery. We can just take out a little bit, and people can get a huge result. So the procedure probably takes about 20 or 30 minutes. It's not very long. It is done with some sedation on board. Full general anesthesia with a breathing tube and all that stuff is typically unnecessary. But we can typically do this through one incision that's about 1 centimeter long.
So it's really minimally invasive.
Incredibly minimally invasive. There's a 5 millimeter port that we put down, and through that port we have 2 tools. One is used to kind of chip away a little bit of the bone and open up that space a little bit. Very, very, very small amounts. We're talking about like tiny amounts. And then the other one, it's kind of looks like an ice cream scoop almost, and we go in and we scoop out that thick ligament. And like I said, it usually takes about 20 or 30 minutes. Minimal recovery. I think with all these that I've done, I've only written like pain medicines for like 1 or 2 people. And we usually have really good results. People will respond to this procedure in one of 3 ways. One, they'll get like immediate relief. It's not uncommon that patients get up and say, man, I already feel better just walking out of the surgery center after having the procedure done. 2 is that sometimes it takes a couple of weeks for patients to get pain relief, so that maybe there's some swelling there. I don't know that I have a real good reason for that, or know that there is an identified reason for that. But those patients take about 2 weeks to get the full result, and then there's another group of patients who will get that full relief in about 2 months. But
some people walk out immediately.
Yeah, certainly we see people. Majority of what we see is in that first 2 weeks, and people I think are very happy with that procedure. The great thing is that it doesn't prevent you from having a big say it didn't work well for you, or you still needed to have a surgery. It doesn't prevent you from doing that down the road. It's really as safe as an epidural injection based on the studies that have been done. I've found that it's similar in my practice as well. So I think that if you have that issue, see if you're a candidate for mild first. Try that first, and if that doesn't work, then maybe you can still have a surgery if you need it. But shouldn't we try like the least invasive thing first before we just jump to surgery?
Oh, I think that's great. So basically, they can try that before they go in and get the hardware put in. This is
correct.
Worst case scenario.
Correct.
It doesn't work, and they can still go forward with the next thing.
Correct. And there's a lot of circumstances where it does help. Our patients, a lot of them with this procedure are 70, 80 years old.
Oh, wow.
Yeah. They probably Well, they don't want to have a big back surgery for a lot of reasons, okay? Maybe they have a heart condition or a lung condition and they can't tolerate a big surgery. So this is a great option for people like that. I mean, little to no recovery time with this versus if you have spinal stenosis, you're probably going to get a fusion. It's probably going to be multiple levels if you're that age. You're talking several months to a year recovery.
Wow.
So that's not a small thing. And a lot of people, they're like, look, I don't have help at home. I live alone. You know, my kids live in Colorado or California or wherever. They can't be with me for months at a time to recover. So there's a lot of reasons for people maybe to opt to do this first before they would have a back surgery.
Thank you for watching today's video. If you found value in this, please like, comment, or share. If you know anybody that is suffering from neuropathy or failed back surgery syndrome or any other debilitating condition, please share this with them so that they can get the help that they need.